Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. I'm your host, Dr. Kevin Hopkins, a family medicine physician and senior physician advisor here at the AMA. Today's rapidly evolving healthcare landscape has created more challenges for the healthcare workforce maybe than ever before. Long work hours, staff turnover, endless administrative chores, the list goes on and on. Although these challenges have been well documented, less is known about the personal toll that these stressors take on healthcare leaders' work-life balance, personal relationships, and overall sense of isolation. But a recent study published in Mayo Clinic Proceedings has pulled back the curtain on the impact of work on personal relationships and physician well-being. Today, I'm joined by our guest, Dr. Mickey Trockel, Director of Evidence-Based Innovation for the Stanford University School of Medicine WellMD Center, and the Scientific Chair for the Professional Well-Being Academic Consortium. Dr. Trockel's development of novel measurement tools has led to growing focus on professional fulfillment as a foundational aim of efforts to promote physician well-being. His scholarship also identifies interpersonal interactions at work as a modifiable core determinant of an organizational culture that cultivates wellness. Mickey, thanks for being willing to speak with me today, and really excited and interested to hear some of your wisdom and experience. So thanks for joining us.
Fun to be here. Thanks, Kevin.
Sure. So this recently published article that I mentioned is titled The Impact of Work on Personal Relationships and Physician Well-Being. And certainly that's what we're going to spend our time focusing our discussion on today. But before we get into that, Mickey, would you mind telling our listeners a little bit more about yourself and your background?
Sure. Professionally, my first interest was population medicine or public health. And I remember the classes that seemed most interesting centered on things like the health effects, physical health effects of attitudes and relationships. And that carried forward when I did my training as a physician in medical school and a PhD in public health concurrently at the University of Illinois. I noticed still that was my area of interest. And so I ended up a psychiatrist focusing on population health. And eventually I got into focus on clinician well-being, physician well-being specifically.
So what led you to an interest in transitioning from population health work to thinking about specifically physician well-being as a focus?
I saw physician well-being as another population health opportunity, a specific population that has rippling effects. If we can improve the well-being of our colleagues, of physicians, then we improve their lives directly, but also then influence the lives of everybody that they care for, which is a lot of patients.
So thank you for that. Can you describe for me the idea behind this study specifically? What were you setting out hoping to measure or prove?
Yeah, certainly. And I think that the background goes back to when I was thinking about my own personal experience with the impact of work on personal relationships. It seems that the acuity of the issues that we help patients with and the workload that we have to deal with in any given day can easily eclipse the more day-to-day but lower acuity needs of those we love in our personal relationships. So I saw how easy it was to get out of balance, and in fact got out of balance and had to do some course correction. And realized quickly through my work as a psychotherapist caring for, particularly resident physicians, but also colleagues, that many of my colleagues were in the same boat. It was easy for them to get out of balance. And this seemed like an important area to focus on in well-being for physicians. So set out to figure out how to measure that as part of our measurement work as we assessed the determinants of occupational well-being in physicians. So we came up with a measure a little over 10 years ago. There's 4 simple questions, and these questions I have one stem. The stem of the questions is, in the past year, my job has, and then there are 4 questions answered on a Likert scale from not at all true to completely true. And those questions are: 1, made it harder for me to nurture existing personal relationships. 2, made it harder for me to develop new meaningful personal relationships. 3, contributed to conflict in my personal relationships. And 4, contributed to me feeling more isolated or detached from the people who are most important to me. And we saw, as soon as we started using that measure, that it was a strong predictor of burnout. And not only that, in an early study, we saw that it predicted unsolicited patient complaints from the patients that physicians were caring for. So when physicians are affected by their work in a degree that markedly impacts their personal relationships, it seems to correlate with less satisfaction in the care they're able to deliver to the patients they're serving. And so with that, we wanted to see how a national sample of physicians might score on this measure and what might predict greater impact of work on personal relationships in a population of physicians.
And all of that aligns with some past research, right? And things that have been written about as far as physicians who are maybe suffering from burnout have less meaningful interpersonal relationships, maybe increased risk for divorce. I've also read less robust positive feedback from patients. And certainly we know it can also contribute to increased medical errors, those types of things. So it sounds like the idea that you had and a novel way to measure it sort of aligns with what's been postulated for a long time.
Yes, and this earlier study, also published in Mayo Clinic Proceedings, demonstrated that even more than burnout, this specific measure, impact of work on personal relationships, was a solid predictor of unsolicited patient complaints. And we looked at several measures, and the association between physician well-being and unsolicited patient complaints was most robust for this variable, more so than with depression, anxiety, burnout, or professional fulfillment, or sleep-related impairment, which were the other measures we looked at in that previous study.
Are there other personal characteristics that perhaps put someone at increased risk of burnout and may also contribute to degradation of interpersonal relationships?
Yes, one that we see is markedly more rampant in physicians and workers in other fields, as is impact of work on personal relationships, is a variable we call self-valuation. Many call it self-compassion. It's made up of two components. Failure of self-compassion, first component being more of a condemning response, self-condemning response to errors and imperfections, as well as the second component, which is deferred self-care in order to serve others. And when those are out of whack, when self-valuation or self-compassion is low, then that's a strong, strong predictor for physician burnout, and a remarkably powerful correlate with negative impact of work on personal relationships. So those two are very, very related: impact of work on relationships and low self-valuation.
So do physicians seem to be harder on themselves than other people?
They do. Yeah. In a previous publication, also in Mayo Clinic Proceedings, we demonstrated that compared to workers in other fields, physicians are much more likely to be hard on themselves in the context of errors or imperfections, and much more likely to defer self-care. And the interesting finding in that study was that deferment of self-care wasn't just about work hours. When we stratified by work hours, at every work hour category, physicians were much more likely than workers in other fields to indicate that they are putting off their own care of themselves due to time pressure.
What are the biggest factors in that? Why do you think that we as physicians defer self-care?
Well, and that's the interesting thing. Yes, the question said due to time pressure, but at every work hour category. So even when physicians and workers in other fields were both working 50 hours a week, or comparing those who are working only 60 hours a week, physicians were still much more likely to handle time pressure in a way that deprioritizes care of themselves. That comes from a strength, in part. I think physicians are oriented to value serving others more than valuing taking care of themselves. And that can be a real value add in providing compassionate patient care. And for brief periods of time, like getting through a workday or getting through a difficult night of an onslaught of patients who really need our help, that can be really important and useful. But when it becomes a mindset that then permeates everything we do, then we get out of whack and it's not sustainable, and impacts our personal relationships.
So it's interesting to have this conversation today. I was in clinic seeing patients this morning, and a patient of mine who I've known for a long time, who has had some serious health issues recently and has seen multiple physicians within our health system, and said to me, you know what I've noticed about the doctors that take care of me? And I said, what? And I expected him to say something like, oh, they're so kind and compassionate. And what he said was, they don't seem to take very good care of themselves. He said, you all seem stressed out and it seems like you need to take better care of yourself. And it just made me think, you know what? He's right.
We tend to get better. The good news is by the time physicians are in their 60s, most of them have learned and are doing quite a bit better in their self-valuation or self-compassion. But we can accelerate that learning curve and find more balance earlier, for sure.
Yeah, absolutely. There's a great opportunity for improvement there. You mentioned those 4 questions, Mickey. In the past year, my job has, you mentioned the effect on being able to maintain existing relationships, develop new relationships, about conflict, and about isolation. Do any one of those 4 correlate most powerfully with the research as far as outcome?
We designed the measure to work as a question set. So we don't typically use the items one at a time, with one exception. Because real estate space was so sparse, we did use one item, which seems to be good as a general measure, as good as can be with a single item. We do lose something in the way of reliability and validity when we drop down to a single item. But the one item we used to compare physicians to workers in other fields in our recently published study was the 4th one, which was, in the past year, my job has contributed to me feeling more isolated or detached from people who are most important to me. We used the whole scale for all of the analyses of the physician population itself, but then for the population comparison where real estate is so scarce, we just used that 4th item. And as you might expect, physicians were much more likely to endorse that, in fact, their job has contributed to them feeling more isolated or detached from the people who are most important to them than workers in other fields.
Great. Could you maybe walk us through some of the other significant findings from the study?
Certainly. So in the physician-only analysis, predictors of higher impact of work on personal relationships were being female compared to male, 26% greater odds of moderate or high impact of work on personal relationships. Being married versus single is protective. Married physicians have 41% lower odds of being at a moderate or high impact of work on personal relationships. Specialty seems to matter. Emergency medicine, perhaps because of the erratic schedule, almost twice the odds of moderate to high impact of work on personal relationships compared to internal medicine subspecialties, which is the larger group that we tend to use as a comparison group in this national study. Physical and rehabilitative medicine, 67% higher odds of moderate to high impact of work on personal relationships, again, compared to the internal medicine subspecialists. So in addition, we saw a strong relationship between moderate to high impact of work on personal relationships compared to physicians who score low on this scale. Moderate impact of work on personal relationships was associated with 3.77 times the odds of burnout. And then high impact of work on personal relationships was associated with 13.59 times the odds of burnout in physicians. So markedly strong relationships between impact of work on personal relationships and burnout. In fact, we're finding in all that we've measured and all the determinants of burnout that we've researched, by a small margin, this is the strongest determinant of burnout. By a small margin, I say because low self-valuation is a close second.
Okay. Yeah, I was going to ask about your thoughts about the association with burnout. It seems logical that there would be a correlation. And as you mentioned, some of those medical specialties that have higher rates of burnout among them, it sure makes sense that there would be a correlation here.
Yeah, indeed. And I already mentioned the disparity between physicians and workers in other fields in the single item that we compared, which is the contributed to me feeling more isolated or detached from people who are most important to me. One other interesting finding related to that is when we look at the effect of being a physician on burnout. In this cohort, this national study cohort, like all the previous cohorts where we've done similar analyses, physicians are at a higher risk for burnout. They have a 40% greater odds of burnout compared to workers in other fields. After we adjust for this single item that we used as a comparison for impact of work on personal relationships, then physicians were no longer at higher risk for burnout. The odds ratio goes down to 0.93, so indicating a slight but statistically insignificant protective factor of being a physician compared to workers in other fields in risk for burnout. So that means that variables like self-valuation and impact of work and personal relationships are the lesions that separate physicians from workers in other fields in creating a higher risk for burnout, at least in theory. We only have cross-sectional data, so we can't say that with confidence, but it makes theoretical sense, and all of our results are pointing in that direction.
So it's so interesting to hear you say, like earlier in our conversation, when adjusted for work hours, physicians have higher negative impact on personal relationships due to work. Lots of different factors. And so my question is, any insight into why that is? What is it about being a physician that leads to more negative impact on our close personal relationships than maybe some other professions? Is it the person, or is it the work?
Yeah, I think it's a combination of things. Al Bandura, the most quoted psychologist ever, talked about the reciprocal relationship between attitudes, behaviors, and the environment. And physicians both shape their social environment in the places where they practice and are shaped by it, starting in medical school. And we have a culture that has a lot of strengths. And some of those strengths have Achilles heels that get us in trouble in some of these areas. These strengths, I already mentioned one of them, which is a high propensity for compassion for others more than valuing self. If you think about our training, that is really drilled into us. It's reinforced, and it's good. I think we need that. We want that in our physicians. It's a true strength. And yet, taken to an extreme and allowed to be out of balance, it's easy to see how that can lead to low self-valuation in ways that cause problems and make highly compassionate care for our patients unsustainable and get us in trouble in our personal relationships. Another real strength, we know this is a strength because psychologists have demonstrated the strength of deferred gratification. You might remember the marshmallow experiment, where when 3-year-olds were given a marshmallow and told if they just didn't eat it, they'd get another one, and then allowed to sit with the marshmallow for a time. And some of the kids waited and were able to get a second marshmallow, and others didn't wait. And then they followed these kids, and those that waited and got more marshmallows did better in life. Well, medical training is the ultimate marshmallow experiment. It's long, and we defer gratification. We get really good at that. Unfortunately, that can have a negative impact on our personal relationships. Since there's always a high acuity and always a plethora of things to do, if our mindset is deferred gratification, then that might work in a short time in personal relationships. But over time, we miss the moment-to-moment joy that personal relationships give us, and miss out on providing a full measure of that for those that we love and who love us. So that's another area. And then a third is, we're really good at focusing on and solving problems. If you think about all of our, early in our training, we didn't have to spend a whole lot of time explaining all the things that were going perfectly in our patients' wellness. We were taught to identify and think about how to solve the worst stuff, the scary stuff, the problems. And that too, if it becomes a mindset where our orientation is to solving problems, can lead to missing some of the gentle, soft, good things that happen day to day that are the substance of the things that are joy in personal relationships. So 3 strengths that we need in medicine, and all 3 have an Achilles heel. And we shape our environment, are shaped by our environment that in ways that produce those things.
Those are great examples. Thank you for sharing them, Mickey. I've told this story probably a lot of times, but You mentioned being a problem solver, and you're right. We want to identify the problem and how to fix it. And I can come out with a 3-step plan for how to do it. But not everybody in our lives, especially in our personal lives, is looking for us to solve their problems. My wife and I are getting ready to celebrate our 20th anniversary coming up this fall. And I had to learn early in our marriage to ask a clarifying question when we would have a conversation, because I would have to say, do you want me just to listen, or do you want me to fix this? Because how I approach it is different. And it was affecting our relationship when I was trying to fix everything. And what are some of those things that healthcare systems or organizations should look at this developing research that's coming out? What should we look at, and how should we think maybe differently about our organization and health systems and the physicians and other caregivers who are taking care of patients within it?
Yeah, absolutely. I think the most obvious that we all can agree with quickly is where you started, with the mounting challenges that we face in healthcare. And so work to optimize workload is high on the list, and creative use of AI and other strategies for team-based care will get us there. Chris Sinski, as you know, has done some good work on best practices to get rid of some of the waste in use of physician time and optimize our workload. Also, part of that is attention to reduce clerical burden. There are some requirements that could be offloaded and perhaps even retired, sunsetted in what we ask physicians to do in clerical work. For procedural specialties, we can take a good look at improving the accuracy of surgery scheduling to create more predictable end of work days. It's distressing if on more days than not, ending of work is entirely unreliable. Things as simple as showing up on time to the daycare to pick up kids becomes an uncertainty, and so that's not sustainable. So that's a clear area of work for some organizations in particular. Then there are simple things like inbox coverage systems, so that when people go on vacation, they're unfettered by work responsibilities. And then there's our cultural work, creating a culture where we not only allow and tolerate, but actually encourage and support our colleagues in taking time for vacation and taking time for meaningful relationships outside of work. And that, I think, has some tailwinds. That cultural piece plus the practical strategies that we just briefly outlined. The tailwinds is coming from our Surgeon General's efforts in seminal work on ending our epidemic of isolation. Vivek Murthy, on page 61 of that document, anyone can find it on the internet, and search Vivek Murthy and epidemic of loneliness, and it pops up. Page 61 suggests specific guidance for workplaces. And here it is. I'll read it word for word. Put in place policies that protect workers' ability to nurture their relationships outside of work, including respecting boundaries between work and non-work time, supporting caregiving responsibilities, and creating a culture of norms and practices that support these policies.
Yeah, thank you for sharing that. If I'm remembering right, I think the first information that was coming out about the epidemic of isolationism actually preceded COVID. That was starting to be noticed, certainly in Europe and other places, and it hasn't gotten better. If anything, it's gotten worse.
That's right, exactly. And this is one piece of the solution. Physicians encouraged and enabled to attend to the health of their personal relationships.
You mentioned some of the things that organizations can do, and I think you even used the word some simple things that they can do. And even though it seems simple to be able to reliably understand when work starts and when work ends, these are solutions that aren't at all common. Even thinking about the vacation coverage and inbox coverage, we know from surveys that most physicians on a day off spend at least 30 minutes doing their EHR inbox. And so it's not all that common, is it?
Exactly.
All right. Any other significant thoughts or pearls of wisdom that you think would be helpful for our audience to hear as a result of of your experience, expertise, or this study specifically?
I think I'll just reemphasize the congruence between high self-compassion and mitigating negative impact of work on personal relationships. They do go hand in hand. And one of the reasons for that is that we tend to have a double standard. Physicians perhaps more so than others, but I think all people to some degree. And the double standard is propensity to have more tolerance for others' errors than my own errors. Others' errors can be met with compassion. Our own errors are often met with more of a sense of condemnation. And the reason I think, one mechanism, and not the reason, but one reason that these two constructs are so related, low self-compassion, low self-valuation, and negative impact of work on relationships, is that the one place where our double standard tends to fall apart and we expect of others the same standards and the same capacity that we expect of ourselves is in our most significant personal relationships. So we tend to gravitate towards seeing others that are closest to us in the more similar, harsh way that we judge ourselves. And so that, I think, is the pearl of wisdom that I'll conclude with, that being more compassionate with ourselves and learning to have a growth mindset in the face of errors and imperfections is a first step towards being able to stand on solid ground and solve the problems that otherwise negatively impact our relationships as we try to balance things in our work life day to day.
Things that aren't easy, but certainly skills that can be developed, learned, and cultivated. Dr. Mickey Trockel from the Stanford WellMD Center has been our guest today. Mickey, thanks so much for sharing with us your expertise and your experience. Listeners can find a link to Dr. Trockel's research in this week's episode description. We also mentioned opportunity to find more efficient workflows and decrease workload and reduce clerical burden. A lot of tools and resources that relate directly to that opportunity can be found in the AMA Steps Forward series, also in the AMA Debunking Regulatory Myths series. Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.